in Cook County to think through with some of the hospital and government partners, along with CHW experts, sort of what are the opportunities to make sure that we are really integrating data and strategies related to community health workers and other peer workforce into this community health needs assessment process. So we'll give a little background on what that process is for those of you who are less familiar. But before we dive in, I wanted to give Stacy an opportunity to sort of introduce this meeting as well, and then maybe go around and do a round of introductions. So I'll turn it over to you, Stacy.
Great. Hi, everybody. It's really nice to see you. I was really excited to talk with Jess and Lucy last week a little bit about this convening. And, you know, I think we all know that now is just an exciting and critical time for community health workers as, you know, the Biden administration invests in more in communities and has said they aim to triple the number of CHWs throughout the country to prevent and treat chronic conditions. Now is a really great time to, you know, kind of double up our efforts. And, you know, we all know too that Partners in Health and a number of other signatories have called for the creation of a national community-based public health job corps. And I know we've all been involved in a lot of conversations locally around, you know, getting and successful at, you know, getting legislation passed that will create certification and reimbursement pathways for community health workers that I know many of us have been involved in for quite some time. And, you know, that, you know, Margie and team are helping to lead efforts to develop locally a public health workforce strategy and collaborative. And we've also been talking, you know, from time to time around, you know, should we be developing our own kind of localized coalition and ways to collaborate around community health workers locally? And so we're really hoping that this conversation can be, you know, maybe a jumping off point for that. So anyway, just really glad to be here. I'm looking forward to the conversation and really looking forward to discussing community health worker interventions within the context of community health needs assessment. So I did not introduce myself. For those of you that don't know me, I'm Stacy Agnafo, the Director of Community Health Innovations for the Sinai Urban Health Institute. I have the honor of working with our wonderful community health workers and helping to develop interventions to meet the needs of our communities. And we've been doing work with community health workers for 21 years now. And so really happy to see the awareness and excitement around community health workers and building the workforce. So I'm gonna pass it over. Please just introduce yourself, your organization, and your work with community health workers. I'm gonna pass it over to Margie.
Oh, and I wasn't even on silent. So I'm outside. So hopefully somebody tell me if it gets too noisy. Nice to see everybody. I know lots of you, but not everybody. Margie Shaps. I'm the director at Health and Medicine Policy Research Group. And many people who we were supposed to be on another call today, right now for some of us. So Health and Medicine has long been engaged in the struggle to get where we are now and where we'll be going in the next several years on community health workers, and historically worked with Letitia and others in and Robin Gable and the governor's office when Governor Quinn was the governor to develop legislation that set up the first task force on community health workers, the precursor to the wonderful bill that was passed this spring. Currently, Health and Medicine is leading with a new group called the Public Health Workforce Collaborative that is employers, largely employers like public health departments and universities, and to think through what are the workforce challenges to creating a really robust and adequate public health workforce. And I, you know, as Stacy said, and Stacy, that was so eloquent, I think your opening, and as you said, now might be the moment where we really can think about what's the right public health workforce and how do we get there together. And so many people are talking about community health workers. That table, that Public Health Workforce Collaborative, is talking about community health workers and a public health reserve. So I bring some wisdom from from that group, I hope. And also I'm working, our group is working closely with Kim and others at SUHI on a pilot program. It's 3 years old, so I don't know if we can call it a pilot anymore, but a 3-year-old program in the western suburbs that's a learning collaborative of community health workers. Really exciting, 5 different types of organizations. And I'm probably talking too long. So that's enough from Health and Medicine, but I'm really glad to be part of this group and think together with you guys. So do I pass it on, Stacy, or are you gonna call on? Okay, I'll pass it to who's next to me. Dwayne, you're next to me.
Hi, can everyone hear me okay? Perfect. I am Dwayne L. Simmons. I'm here at Loyola Medicine, which comprises Loyola University Medical Center, McNeil Hospital, and Godley Hospital. I am here currently serving in a fellowship capacity. I'm one of the new administrative fellows in the Office of the CEO. The fellowship experience allows me to get exposure and experience in a variety of different administrative areas in the hospital. And one area that has jumped out at me throughout my studies is how do we get patients from that white space to a better care delivery model, and how do we incorporate more wellness activities and not just acute sick care within our care delivery model. So I was had the opportunity to join the call. So I'm here to help in any way I can. My background, I do have an executive MHA from George Washington University, a doctor of pharmacy degree from Florida A&M University. I've been a clinician for the last 11 years, so happy to help however I can.
Maybe Venencia and others from Loyola, if you want to introduce yourselves.
Sure, I can go next. I'm Michelle Calva, and I am the coordinator for community health and wellbeing for Loyola Medicine. And I'm also the most recently appointed community health worker.
Thanks, Michelle. So I invited both Michelle and Dwayne to join today. Michelle, again, is our community health worker. I am the new regional director of community health and wellbeing at Loyola Medicine, and glad to be a part of this group today to discuss the role of community health workers and CHNA. Thank you.
Do folks from the coalition want to introduce themselves? Leticia, I think you're on the phone. And Wandy?
Hi, yes, Letitia Boughton Price, Illinois Community Health Worker Association. And our role is really to protect and advocate for the essence of community health workers, while also working to grow and sustain the CHW workforce here in Illinois. We're a membership organization, have been doing this work for community health workers dating back to the late 90s. And one of our most recent successes has been this legislation that was recently signed by Governor Quinn that opened up a payment source through Medicaid, but also sets up a board to look at certification for community health workers in Illinois. And many on the Zoom meeting has been a part of that process. And I am grateful for that. And we will just continue to work and move forward with advancing CHWs here in Illinois. So with that said, I think I would like to pass it to Micah.
So much. Hi, everyone. My name is Micah Schoblum. I am Vice President at NORC at the University of Chicago. And I've had the pleasure of being able to work closely with the Chicago Cook Workforce Partnership, and Claudia very closely, as well as Stacy, and supporting the contact tracing core and the number of grants that were put into place last summer. My team is responsible for running what we call the Resource Coordination Hub, and we staff a number of navigators who have begun to really canvass the city and working with different community-based organizations, really looking across the board at established community-based organizations, but also hyper-local efforts through the CDPH direction of making sure that we can be present, the hub itself can be present within the community level to be able to provide neighbors and residents the type of local needs and support that they have. So we spend some time, our team spends some time reaching out, focusing on the Chicago plus communities and neighborhoods where we're really seeing the COVID pandemic impact some of the hardest hit communities, finding these organizations, maintaining connections on what types of support and services they provide, in turn being able to spin those around to residents who call in looking for needs, particularly within their given communities. So my background is more on the research side, but we've been really just, it's been a great learning experience. I've noticed several faces and on the call today that we've been able to engage with over the past year here. So thinking about community health worker from a little bit of a different vantage point of the role of having a network, a hub of different types of organizations and services that can best meet the needs of residents across the city. Since I went, probably better for Claudia to go first. I'll hand it off to Claudia to continue the intros.
Thank you, Micah. My name's Claudia Catuz Regalado. I am the director for the COVID-19 response project. I work for the Chicago Cook Workforce Partnership. We're the LCO for the $56 million grant that was provided from the city to manage the contact tracing core of 31 CBOs across the city of Chicago. Well, since then, you know, our core has expanded in the manner that we are not only doing contact tracing, but we also support CDPH with the vaccination pods. We established a COVID hotline, which supported the scheduling for the United Center and the other city vaccination pods that came after, like the Chicago State University and so forth. We are currently also canvassing on the ground. We are doing door to door. One of our other initiative is the Promotoras de Salud, or Promotores de Salud / Community Health Workers initiative, or prototype of it. I'll say after I learned a little bit from Letitia last week. And then we are also, a lot of community outreach. So I think that, well, we just completed year 1 and we just got renewed for year 2 because there's still more work to be done around the vaccination and the hesitancy in our communities. So all these 31 CBOs are located in the areas that is most needed, mostly in the Black and Brown communities. And the people that got hired to do the contact tracing / response core are community members from those areas, right? So who better to do the work than individuals that live in the community? So I think that my role for, or goal for year 2, being that it's the last year, is how do we help these 500, up to 500 individuals that have been doing this community work for the past year plus, and develop them to hopefully be the future of community health work or / public health / healthcare opportunities, right? So thank you for the invitation, because I am, my goal again is to help individuals as a workforce development professional, how we take these individuals to the next level of their careers, being that many just probably got introduced to this field just last year, right? So, and many have grown to be passionate of the work that they're doing. So I really am seeking to you all as experts in this industry on what we could do to be able to help them move on to the next level. I'll go ahead and Priscilla, one of our partners.
I had a feeling. Hi, everybody. My name is Priscilla Bolander. I'm a program manager directly under Stacy at Sinai Urban Health Institute. And I participate in a few different groups that were mentioned in the contact tracing core with Claudia and the partnership. with Letitia on the workforce development subcommittee with ILCHWA, and then in the public health workforce collaborative, which has been very, very interesting to participate in. So I'm happy to be here. I will pass it to Kim.
Did you say me? Virgos, yeah. Hello, everyone. My name is Kim J. I am the senior CHW consultant and trainer with Sinai Urban Health Institute. I've been there for 9 years. I've been very intricate in a lot of onboarding of new community health workers, especially with the contact tracers as well. As I look around, I've been in so many different positions around this board collectively that if I talk about it, it'll take the entire time. But just to know that I've been involved in a lot of new initiatives, one being the Western suburbs, the other being, again, the contact tracers that were onboarded and getting them acclimated to the world of community health and answering any questions or concerns they may have had about the process. I've been intricate in developing curriculum, as well as being a board member for the Illinois CHW Association and for the National CHW Association. And that's enough of that. So I will go ahead and pass it on to Teddy.
Thank you, Kim. My name is Teresa Berumen. I'm the Community Health Worker Program and Hub Coordinator for Rush. Happily work alongside Lexi Artman and Christopher Nolan. So I started two years and 8 months ago at Rush, coming from community-based organizations as a community health worker. And so I started with a small team of 3. I was leading that team under the management of Christopher Nolan, who was just, tremendous and a key to have our hub grow from those 4 that we were originally 2.5 years ago to now almost 40 community health workers who I'm very, very fortunate to be coordinating the program for. We have grown as a result of grants, of course, with the efforts of contact tracing and contact investigation. And as the numbers are, of course, going down. And so we are now getting very much intentional about places where we can have our community health workers work in other efforts in other areas. And so we're expanding and thinking of keeping them long-term. So we're expanding our partnerships both internally as well as externally to be able to use their skills that they've gained, that they're gaining through the work as community health workers. And someone already mentioned some of them are new to the role. So also training them on what skills they need as community health workers and how to become the best community health workers ever. I'm also, very fortunate to work alongside Letitia and Wendy and Kim on ILCHWA. I'm representing ILCHWA as an advocate, being the chair for the board of directors. And then I'll pass it on to Lexi.
Hi, everyone. My name is Lexi Artman. I'm really excited to meet you all today. And like Teresa said, I have the honor of working with her and all of our community health workers here at Rush. I think she summarized the program beautifully, and I don't have a lot more details to add, but I will say that I've learned a lot with her alongside our CHWs, and I'm fortunate to hear from them directly about what their interests are and how we can kind of use that to drive our programming. And it's exciting to be a part of this group where we can all learn from each other in that way. And I can pass it off to, yeah.
Hi, everyone. Good to see everyone. I'm not going to be on camera for all of this because I have to go behind the wheel of a car, so you don't want me on camera for that. Can everyone hear me okay? All right, great. Christopher Nolan, pronouncer he, him. I'm the assistant manager for community health and benefit at Rush. I've had the privilege of leading a lot of our community health equity efforts, including our CHW hub with Teresa and Lexi and Bonnie. who's on maternity currently, but really been involved with kind of getting kind of CHWs into the forefront of this work, hiring locally, focusing on bringing people in from the community that are from the west side of Chicago, which I've gotten to work with so many of you on. I'm also faculty in Rush's Health Systems Management program, where I direct our health equity elective, and then also faculty with Malcolm X as an adjunct instructor with the CHW program. So I've been very involved in this space, and just because of many of you, so I've gotten to get launched into this. Excited to be with you here today. You're going to have very good leaders in Lexi and Teresa. This will probably be my only meeting with you all. As a lot of you know, I am actually going to be leaving Rush at the end of next week and going to St. Louis to BJC Healthcare. So it's good to be with you all now, and I'm really excited about where this work's going to be going. And there's still going to be ways to partner. So I'm excited to see what happens, and appreciate getting to be here at least for this meeting.
Thanks, Christopher. And if I'm taking note correctly, I think we have colleagues from Enlace, Friend Family, and Malcolm X still to introduce. So we'll start with Amanda from Enlace.
Hi, everyone. I'm Amanda Benitez. I'm the Director of Community Health at Enlace Chicago. It's a community-based organization in the Little Village neighborhood. And so we have 6 full-time and 10 part-time community health workers on our team at Enlace. And then they do a variety of health promotion activities and advocacy as well. And then we also convene a local network of Spanish-speaking community health workers called PAIS, or Promoviendo, Abogando y Educando por la Salud. And so in addition to our own 16 community health workers that are part of that network, there's about 30 to 40 other local Spanish-speaking community health workers that also meet monthly through that, and for training, capacity building, resource sharing. And I can pass it on to Veronica from Malcolm X.
Hi everyone, sorry video's off because my internet's unstable. Veronica Seck, I director of the Community Health Worker Program at Malcolm X College. Really excited to see everyone convening here. I feel like I know most people on this call, so thanks for having me.
Thanks, Veronica. And Wendy, I think you may be the last, or I might have missed 1 or 2 others, but go ahead, Wendy.
Okay. Good afternoon. My name is Wendy Thompson. I'm the Chief of Strategy and Development at Friend Health. I think I'm the newest person to this group. We are newbies to, well, actually, we're newbies to having community health workers on a full-time basis working with us. We were introduced to community health workers through our involvement with the Southside Pediatric Asthma Center with the University of Chicago, where community health workers assisted our pediatricians with asthma care. And we expanded that by partnering with Veronica and Malcolm X by hosting an apprenticeship. So we have had 8 individuals who have gone through the Malcolm X program who have been with us, and joining during COVID. They've done pretty much everything. They've been involved with testing, vaccination, care gaps, you name it. They've been there engaging, and we've been really pleased with the program. And now we're looking at the community health workers with a specialty in SUD, in particular to focus on efforts at our subsidiary HRDI. Thank you for having me.
Excellent. Thanks so much. Anyone else that hasn't introduced?
Hi, everybody. Katie Doyle. I'm with Northwestern. I was late. I'm sorry.
No worries.
It's myself and Jen Fulton, my colleague, who wasn't able to make it today, but I'm the director of collaborative care at Northwestern, which is a team of amazing people that help fill all the holes that we know healthcare has and help patients navigate their care. We feel very lucky to be a part of this contact tracing work because of it, we are building the infrastructure for community health workers in our operating models, and we're looking at employment lines and professional development to try to bring more people into our healthcare system to ensure that we have the diversity needed to have the right workforce to support our patients. So this has been a very instrumental project to help improve Northwestern in our efforts. So it's great to learn from all of you, and we're really glad to be a part of this.
Thanks, Katie. So I'm going to turn it over now to my colleague Leah, who's going to give a little bit of background on what is the Community Health Needs Assessment, or what you'll hear referred to as CHNA. I know many of you are familiar, but we wanted to just give a quick background so everyone feels like they're on the same page. As indicated in the invite that was sent around, we're hoping that you all can help us brainstorm around 3 areas today in terms of how the CHNA, or the Community Health Needs Assessment, can lift up and reinforce the work that you all are doing in the community health worker sphere. So one area is what data is already out there or currently being collected and analyzed that we can incorporate into the Community Health Needs Assessment that really speaks to the great work that CHWs are doing, or the gaps or areas for workforce development among CHWs. So data, what data already exists or is currently being analyzed that we could incorporate. 2, what opportunities are there to engage community health workers or other peer workforce within the CHNA process? So that might be through providing direct input for focus groups, but we can also be a little bit more creative. So if there are members here who have existing navigators or community health workers that could be reimbursed for some time to help in collecting surveys or help in providing input into this CHNA process, there's potential opportunities there. So the second is, how can CHWs be engaged during the CHNA to provide sort of community input and engagement into the process? And then the third is, we really want to leverage this countywide community health assessment process to solidify some strategies. Where can healthcare partner with the community to really advance community health equity? And clearly, community health workers are a key strategy for that work. And as several of you alluded to, there are different tables that are currently in the process of developing strategies. So the third question is sort of, how do we make sure to reinforce and lift up those strategic opportunities related to CHWs into the Community Health Needs Assessment? So what data can we incorporate? How can CHWs be involved in community engagement? And how can we use this process to lift up and reinforce the strategic work that you all are already doing? Those are the 3 questions. I'm going to turn it over to Leah so she can kind of outline what the process and timeline is.
Thanks, Jess. I'm going to share my screen quickly here. So as Jess mentioned, this is just a quick overview to just give a little bit of background for those of you who might be new to the process as to why we do this. As part of the Affordable Care Act, the IRS requires that hospitals do assessments, community health needs assessments, CHNAs, every 3 years to assess priority health needs within their service areas and their surrounding communities, and to develop implementation plans to address the health needs that are identified in their assessments. So in 2015, actually, the Alliance was formed. It's a partnership of over 30 hospitals at this point. And we're all working together to do a shared countywide assessment. This will be our 3rd time doing it, with the first one completed in 2016, the second one completed in 2019, and the third expected to be completed in 2022. With that in mind, and this being our 3rd one, a few parameters that we have for the CHNA are that we're doing a lot of work to focus on refining strategies for community health improvement and to support implementation progress that hospitals have made so far. Our CHNA, as was mentioned, will leverage other assessments and plans and other work that's already ongoing. We will be using a racial equity framework to do our assessment, and we will be highlighting opportunities for addressing racial inequities and geographic inequities and other forms of inequity and discrimination. Short and long-term threats and opportunities related to COVID-19 will be analyzed as well. And also this assessment will help us as a partnership of hospitals and health departments and community-based orgs identify shared policy priorities and opportunities that we can work on together in the future. So these assessments are actually take about a year to complete. They're very comprehensive in terms of the scope. So we started the planning process for this cycle of our CHNA in March of this year. Right now, we are working in this secondary data analysis and collection of primary data portion of the timeline. And then we're looking to have, primary data collection wrapped up by the end of this year. We'll be drafting reports for our partners to review early next year. With April 30th being the completion date of these CHNAs, that gives hospitals a couple of months to review these things with their boards and their community advisory committees. And then most of the hospitals in our collaborative are required to publicly post their CHNAs by June 30th of 2022. So this just gives you an idea of sort of the timeline we're working with. So the assessment structure, there are a few different components to it. It's based off of a assessment structure that was created by the National Association of City and County Health Officials. And this assessment structure is currently evolving. NACHO, that organization, is in the process of revamping it. We've been adapting and refining the assessment structure over the years as well. So as it stands, we have one portion of it will be secondary data. So that's that public health data that the health departments are supplying. We also get hospitalization and ED data from our health hospital partners. And we also incorporate data from existing research and a number of local efforts to collect data and do assessment on a more regional or local level. Another source of data we're looking to incorporate into this health status assessment this time is like, for example, social needs inventories that have been taken by hospitals, for example, when they screen for food insecurity or housing instability, when they intake patients into like their inpatient care, for example. So this community health status assessment, that secondary data, that gives us an overall sort of statistical view of what health status in our communities look like. Now, the community themes and strengths assessment focuses on primary data, so data that comes directly from communities. There are a couple of different ways in which we collect this data, the primary ones being through focus groups and surveys. We also convene usually a couple of different regional meetings with stakeholders around certain topic areas, whether it be like housing or mental health. We also engage our work groups that are currently working in different alliance priority areas to give feedback into this process as well. So under this is sort of a list of different types of communities we engage to get feedback on what health priorities and concerns are, as well as understanding how well our implementation activities are working in communities, or how well a proposed implementation activity is likely to work in a community. We hope to use some of the input from communities to understand that as well. In addition to the secondary and primary data, we're also looking at ways to understand how the local public health system is able to address health inequities. In the past, we've done that related to the 10 essential public health services, and we will likely be adapting some sort of process similar to this in this round. The forces of change assessment, that goes back to what I was speaking about, like threats and opportunities related to that could potentially impact health in the near future. So like in the next 3 to 5 years. So the big one being with that, COVID-19. So for example, we would like to understand how COVID-19 impact trends and factors related to it might impact the health of our communities in the next 3 to 5 years. And then we're also writing the entire CHNA from a racial equity lens, but we'll also be looking at ways that we can incorporate different assessments of racial equity priorities throughout the CHNA process. And with that, this is a list of the interconnected priorities that were identified in our 2019 CHNA across our main focus areas. Not all hospital partners are working in all of these areas. Some have priorities in 1 or 2, some are working across several. It really just depends on the capacity of our different partners and also who's best able to lead this type of work. But this is just to give you an overview of sort of the different types or different areas in which our hospital partners are doing implementation activities. So with that, did anybody have any quick questions about the process before we move on to discussion?
Okay, well, so with that, we really did want to just open it up. And I know that Lucy has put into the chat the 3 questions that I had articulated. So we kind of want to just leave this as an open forum for you all to comment on your thoughts about how we can make sure to really lift up CHW and peer workforce within this process. So I'll ask some more probing questions if we need to, but I think we have enough experts on the phone that I'll encourage you to just jump in and share your ideas for us.
It's Letitia, and I'm always glad to be a part of a conversation that elevates the role of community health workers. So once again, I am grateful for your interest and even your commitment to even figuring out ways to get community health workers involved in this process. So I heard that you all are kind of like in this preliminary data collecting stage right now. So you're already you've already put the assessment questionnaire, I don't know the correct term, but you've already kind of put that out there and getting data. Is that am I correct in my understanding?
Actually, we're right before that phase. Okay. So right now we're in the process of reviewing the survey and focus group tools. And we're expecting to deploy the survey in August and hoping to start scheduling focus groups for the end of July into August. That process will be ongoing, but we are hoping to get the bulk of those things scheduled by the end of the summer.
Okay, I'm sorry, because I was having some internet problems and I was just like, well, I'm not seeing the presentation. And so I probably missed that information. And I'll stop right there. But can you add those questions back to the chat? Because since I had to rejoin, I wasn't able to, I didn't see the questions.
This is Michelle Calva, and I apologize. Community health and well-being and this space is all new to me. When you present these slides to community health workers that are not familiar with this space, will you use terminology that they'll understand? When you say assessments and all these other things, it's all new to me. Like I understand some of it, but I'm just wondering, the same presentation, will that be presented to the community health workers when you get like their buy-in or with the CHNA work?
So normally what we would present would be probably a couple of slides that show, what are the hospitals and other partners that are involved in this assessment? What are the priorities that have emerged from prior assessments, where, like the topic areas? What are the question, like 1 to 2 specific questions about each of those priorities that we're hoping to dig deeper with them. That would be the type of information that we would likely present and share. Usually the way that we approach it is that we have a partner who, has said I'll just take the example that Amanda mentioned, the group that she convenes of Spanish-speaking community health workers in the city. We would work with Enlace and probably 1 or 2 of the leaders from that group to sort of define, what are some of the key questions that this larger group would really be able to inform and hone in on 1 or 2 topic areas to focus on based on the input from Amanda and the leaders from that group, and then focus on those topics for that, rather than sharing this sort of like broad conceptual presentation.
Okay, thank you.
Hey, Jess, this is Christopher. One thing that just like being on, so I'm kind of involved with both spaces, obviously with the CHNA, with being on the AHU steering committee. One thing that I really could see CHWs playing an integral role in this process is one, Letitia, you asked about whether or not it's been created. I think getting a CHW perspective on the survey itself and the questionnaire and making sure that it is very clear with how we're asking it. Another area that I could see being really impactful would be integrating this into the COVID efforts. So I'm just thinking about everything that the Chicago workforce is doing with like the door-to-door kind of pieces of things. I just feel like there's a lot of opportunity with COVID outreach to pair this together if there's that kind of agreement and buy-in with CDPH, because I think everyone would benefit in the end. Obviously, you don't want to overdo it, but I think that could be something. And then also integrating this into the CHW process for any focus groups, and like them leading, CHWs leading some of those focus groups. So those are just a few ideas.
That's great, Christopher. It's Letitia. The other thing that I'm a little concerned about, I know this process happens every 3 years, and it's almost like I'm more interested in how the hospitals would support sustainability of CHWs within their systems. Like SUI is doing an excellent job of it, right? And don't get me wrong, Stacy, I like utilizing you all as a nice motto when I'm talking. And I know that you probably can, I'm sure there are areas that you feel like you could do better in or whatever, but you all have a nice model. And me working at the University of Chicago, and it's just so siloed where community health workers are being utilized. And a lot of times they're being utilized based on pots of money, like where they can get the money from. And hospitals have a better chance of sustaining community health workers because they can get these diverse streams of funding. So one area I definitely see support needed from a group like this and the hospitals is, finding those sustainable structures and financing mechanisms for community health workers, like helping us get that down packed. Because again, as we're seeing with the contact tracer movement, as we've seen with Obamacare movement, with the insurance navigators, once these big needs come up, this big pots of money gets poured in from the feds, from state, city, local departments of public health, we create this workforce that was already there in place. Community health workers have been around for decades. And then we stuck with trying to figure out what we're going to do with a mix. So that's why I like, what Margie is doing with the public health workforce creation, like really just trying to figure out, like, how can we be more proactive instead of reactive in these types of scenarios? So long story short, helping groups like mine who are really focused on the workforce and trying to figure out ways to sustain it, but also grow it. And the part of that sustainability has to do with how they're going to get paid, right? We know that the contact tracers, that's their title, but most of them are doing the work that falls up under the responsibilities of community health workers. And some of them can transition over, right? Malcolm X has a training program, SUI's helping educate, in some other capacity. South Suburban has a program, so they can get trained, right? But how can we sustain that? And I think because you're a coalition of 30 hospitals, I'm sure the Hospital Association is somewhere in the mix. Just trying to use that weight, use that clout, use those connections to find ways to sustain and move some permanent things around the workforce forward in Illinois.
Thank you, Letitia. I think that's such a great point. So as somebody who's never really, I've known about our CHNA. I know basically the process. I haven't been totally ingrained in the whole process, but it just seems to me that calling out community health workers and prioritizing their involvement in the CHNA process will bring greater attention to health systems and perhaps how they're using community health workers. So for example, I think part of what we struggle with is that we don't really know, to your point, Leticia, about silos in an institution, not knowing what CHWs are doing, where they're housed, how they're being utilized, what areas of focus they have. I think if health systems can really start to pay attention to that information about how CHWs are deployed within the health system and in the community, I think helps institutions then figure out how to longer term sustain and balance the work in a way. I mean, I just know within Sinai, it took us a long time to kind of get integrated within our own health system. And Kim, correct me if I'm wrong, but I think our CHWs last time were involved in the planning and kind of, providing that insight into the CHNA. Well, fast forward to this year, we're getting ready to hire, 20 to 30 community health workers this year. So I think like this whole conversation in picking like these data points that we need to try to figure out how to track I just feel like that in and of itself is going to help us lead to a bit of system change here. And I've not been involved in the CHNA, but that's just what popped in my mind as Leticia was talking, so. Kim,
Yes,
can you describe how you've worked with the CHNA in the past?
Yeah, so what's been very important is that to have the CHW voice included and also uplifted. What often is kind of disheartening sometimes is that the community health workers are really used to gather critical information, making sure that things are appropriate and proper, and then that information is then disseminated, and then you do get the results that you need. But what I think that is very imperative is that when you use community health workers in these capacities, when you're reporting back, say, yes, the community health worker was used to do this. They were used to refine the documents that were sent out. They were used to, so people can get the essence of what community health workers can do and the diversity of what they can do. So with being at the table with these conversations, we were able to help shape what these conversations or these questions would look like, and how the interaction would take place, because again, you want to be culturally appropriate, you want to be community appropriate, and I think that overall, community health workers needs a huge advocate in a space that's bigger than just our own hospital or our own organization. It needs to be a resounding voice that says community health workers are doing some incredible work in different areas. Ours are working in oncology. They're working in AIDS AIDS navigation, they're working in asthma education, they're working in so many different areas, but as we're not really lifting them up as a collective to say they can do this work, we're saying it against our own organizations, but really they are used in all these areas and arenas to do some really heavy lifting to make sure that the information that's going out is appropriate and equitable. But when it comes down to the dissemination, people go, well, how do you get this information? And they're not really saying the community health workers are an intricate part of getting this development to where it is. And I hope that made sense. If not, I'll try to clarify a little bit more. But I really just think that community health workers can be used to do the facilitation of the focus groups. I think that's very powerful. I think they can be the ones that you use as your resource to get the appropriate information. Because as a community health worker, I appreciate being at the table with the voices that make the change, and then utilizing my experience and my processes to even lend to the masses to say, these approaches are effective and powerful, and then take that and then people go with that. Again, I've been a part of so many organizations standing up their programs and then fortifying their community health workers with knowledge and experience in the trainings. And I think that people forget that community health workers can do that. And the voice of advocacy needs to be in the mouths of those who the bigger people, I'll say the bigger organizations, the bigger picture needs to be the advocate to always speak about it so that it's not a siloed experience, but it's a collective experience that we've all been a part of. But as a collective, it's really not coming out that way.
Eloquent as always, I have to say. And I just like to piggyback on what you're saying, because I really do believe that community health workers can and should be utilized at just about every step in the community health needs assessment process. So for example, I invited Michelle Calva, who is right now the only CHW at Loyola Medicine, into this convening. Prior to that, I forwarded her the focus group questions that to get her input. How does this read, for the community? If you were to offer this to one of your the patients or clients that you work with, how would it be received? How is the wording? So I think that's one area, helping to wordsmith the questions. But then again, as Kim said, actually participating in facilitation of the focus groups, actually recruiting for the focus groups, because people may respond to CHWs in ways that they will not respond to us. And if we really want to get that community level input, CHWs are instrumental in that recruitment process. I think also in helping to interpret the data. Maybe there could be, some language that is not familiar to us, but is very common in those communities. CHWs can look at that. Oh, well, this is what that means. So I think that there are just so many opportunities for CHWs to be engaged, throughout this entire process. And then once we do have, the report, making sure that we are going back to community health workers and saying, this is what you helped us do. This is what it means. This is how it can impact you at the community level. And I also think it's important for CHWs, because oftentimes CHWs are experiencing the same challenges as many of the clients or patients that they may be working with. So at that level, from a personal level, it's also very important to have that input. So hate to follow Kim J, but yeah.
Thanks, Vanessa. Yeah, we've got Wendy and then Margie.
Great. I just want to echo what everyone is saying. I think the beauty and the challenge of a community health worker is that they don't fit into any of the boxes of sort of our traditional, at least in an ambulatory setting, they don't fit into any traditional boxes. And so some lessons that we've learned over the last year is that when we had a group of individuals come in, it was a little, what's the term I want to use? Staff was a little leery, right? Frontline staff, because they wanted to understand where these people were placing them. They were versatile. They could do some of the same things that these individuals were doing. So I just want to point that out, that, it's important that they're brought into the organization in a way that everyone understands
what their role is. And that's sometimes hard when you haven't quite figured it out. But community health workers, what we're now learning, as they become more mature or individuals in the organization, is that everyone is welcoming them. Everyone wants them to work in their areas. One of our community-based vaccine sites is actually being kind of led and managed by one of our community health workers, because in addition to doing the job, they have a level of not just cultural competency, but truly an understanding of what it takes to drive the message, to sometimes gather information that individuals may not be as comfortable saying in a clinical setting. When they go out to community based events, they're engaging on a very personal level. So community health workers for us strike the perfect balance of, being trained and able to adapt to a clinical setting very quickly, but at the same time, bringing basically ensuring that as clinical providers that are sometimes focused on the process, we don't forget the needs that should drive what we do.
Thanks so much, Wendy. That's crucial. And I know we're short on time, so Margie, I'll kick it over to you.
Okay, so just this has been great, and I agree with everything everybody's saying, but several points I would make. So data, Suhi has so much data about and articles around CHW impact on asthma and MCH and diabetes. So there really is a treasure trove, I think, on your website of really good data. I'd also offer up, Kim, we have a lot of data from our Western suburbs experience over the last couple of years of CHW impact in those communities, and it's a lot of data. So other stuff I would say, advocacy. I think the point that Letitia brought up earlier about sustainability, I worry a lot about that with all the influx of money coming in the next few years, that it'll go away, and then so will the program. So I think we have to engage the hospitals and maybe CHNA. I'm not positive, but maybe that's a vehicle to engage hospitals in the advocacy work that needs to be done with HFS and with the Medicaid managed care organizations, to make sure that there is a permanent source of funding, at least through Medicaid and maybe through the MCOs, for the work that the CHWs do. And then I think collecting stories of how CHWs pivoted during the COVID period can be really powerful, particularly for the hospitals maybe that haven't had CHWs on their staff. And I'm not, I think there's lots of ways to do that. Just happy to talk about that, and we can all brainstorm about that. So those are all my points.
Excellent. And I think that really summarized a lot of the key points, in addition to the many ways that folks suggested really directly engaging CHWs throughout this whole process. So know that all of you really made an effort to be here today. We so appreciate it. And we will stay in touch over email and probably be in touch directly with many of you. Feel free to reach out to us. You have Lucy's email and ours. So thanks so much, everyone, for all of your time. And it was great to see all of you and meet some of you. And we look forward to continuing to work with you all.